Good morning, everyone. I just wanting to remind you that you need to turn your cell phones off so that you can have a productive and a respectful learning environment. We want you to get as much out of this session as you can. We will be talking about alterations in integumentary today, and we will be doing both a theory and a skills session. So you'll need to be listening to both of those today. Thank you. Hi, this is Susan Panter for NURS2244. Today our theory session is over alteration in integument. We will be discussing burns. In IGGY, your reference book, chapters 24 has an overview of just the skin itself, and then chapter 26 covers our burns. So first off, let's look at the functions of the skin. The skin is our protector, the protection of a coat on our body that will allow for our body to protect from infection. Anytime there's a break in the skin, we know that there is at risk for infection. So again, we can't emphasize enough that number one priority function is the protection of infection, and also utilizing good hand washing is our number one action for nurses to protect our clients with any kind of alteration in integumentary. Another function is homeostasis of water balance, also temperature regulation, helping keep our body at a set temperature, whether it needs to cool it or warm it up a little bit. Sensory, so touch and feel happens to be one of the functions. Also looking at vitamin synthesis. In particular, vitamin D is activated through the skin. And then lastly, psychosocial. We know that if we have any severe alterations in the skin, it can affect our body image, appearance, and identity to a patient, so that becomes an issue that we have to deal with also. This diagram of the skin just shows all of the different layers of the skin, and also including the appendages of the skin. So I just want you to review over that. And again, the alteration that we're going to be discussing will be our burns today, and you may notice in readings that you may see them called burns, or they may be called also thermal injuries. Pathophysiology related to burns results in tissue destruction of the skin layers and the underlying tissues. Does affect the normal skin function, and we can see local and systemic complications that can occur from this. Might include fluid and electrolyte problems, sepsis, metabolic changes, endocrine changes, respiratory changes, cardiac changes, hematological changes, and also problems with immune functioning. So again, the extent of the problem is going to be related to our patient's age, the general health, extent of the injury, and the depth of the burn, and then also specific body area that has been injured. When we have a break in the integument of the body system, especially when they are from burns, other body systems are affected, just like we talked about, and that's why we have issues with multi-system disorders that can occur. So listed here, you'll see the affected systems, and then there's a big picture here that is also in your book that just kind of outlines a few of the problems in the areas. But our skin, again, notable alterations depending on the degree of burns is what we will see. And number one, there's a break in our defense protective barrier, so our patients are at very high risk for infection that can lead to sepsis and other problems. Also, we can see vascular issues that are affected that go right along with our fluid and electrolyte balance. So we may see some profound imbalances in some of the fluid shifts, and also with cell damage. So some of the lab work that you might notice that would be off with our patients would be hypovolemia, metabolic acidosis, hyperkalemia, and hyponatremia. So those are some of the major areas that you're going to see lab work changes in. Our next topic here is cardiovascular or cardiac. And again, that begins immediately following a burn and Again, that includes the hypovolemia that we talked about in the vascular. However, it also leads to decreased cardiac output. Our next topic is pulmonary. So we have to remember to protect the airway no matter what, especially when our patients have been burned in a closed area, so like an inside area. If they've inhaled anything, whether it's smoke or whether it is chemicals, they have a big chance of having an airway that can be obstructive. Protecting patients or actually looking at potential carbon monoxide poisoning can occur. Then we have damage to the alveoli and leaking of the capillaries, and alveolar edema can occur, and this can occur up to 1 week post-injury. So at first we may not see any problems, but if you see a patient that has blackened soot, or you know that they've inhaled smoke or chemicals up to a week, you need to be alerted that they may have a respiratory problem that could occur. And again, symptoms can be delayed for 24 to 48 hours, and so we just need to be extra cautious with our patients there. The gastrointestinal system is also affected, causes a decreased flow, and sympathetic stimulation can occur. So we'll see a decrease in our peristalsis, which can eventually lead to paralytic ileus and the bowel not moving at all. Many patients end up having an NG tube placed. Number one, it will keep their GI contents down. Number two, it will help prevent aspiration pneumonia. And then your book talks about the Curling's ulcer. This can occur within 24 hours after the body has been put under increased stress. So this is like having a stress ulcer in the stomach. They just happen to call it a Curling's ulcer post severe injuries. Next bullet point there is metabolic, and in that is included the renal and thermoregulatory. We have increased secretions of catecholamines, antidiuretic hormone, aldosterone, and cortisol levels. So the problem with that is we have oxygen and caloric needs that are increased, and so our body is unable to keep up with those increased needs. Aldosterone secretions will increase as the result of endocrine response to the stress healing, to increase sodium reabsorption by the kidneys, and sodium will move quickly into the interstitial spaces, and then we'll see deficits in the blood occur due to sodium trapping. So we're going to see lab levels that are going to be increased, such as dehydration. So we'll be noting our hemoglobin and hematocrit levels start dropping. We also will see a decrease in urine output, specific gravity will increase, our blood viscosity will increase, and we'll see some hypoxia that can occur from all of this. Thermoregulation, again, our skin helps us to maintain our body temperature. So with loss of that, we're going to see problems with our temperature. Our core temperature is going to increase as a loss of heat through the burns, and then also we may have patients that have low-grade fever with that. And then immunological, again, we've talked about that. It is our protective barrier. So most patients are going to be put on antibiotics, but our protective barrier has been disrupted. And so because they get put on antibiotics to prevent, that's also going to affect our overall immune system. So again, as you look at this slide, I just want you to think about how burns can affect every system and multi-systems in general. This diagram just shows how burn trauma and cardiovascular system are affected with each other. So you can see a series of fluid shifts that occur, redistribution of water, salt, and proteins, and then we have an increased capillary permeability, which allows extra fluid to leak into the interstitium. This causes a marked decrease in circulatory blood volume, but it looks like our patients are overhydrated and edematous. And again, the diagram on here shows a really good picture of what happens with the cells and the fluid shifts. And on this slide, this just breaks it down a little bit so that you can see like linear what happens in the body. So when we have a burn, We have increased systemic vascular permeability. On one hand, we have interstitial edema, decreased blood volume. On the other hand, we have an increased hematocrit and increased blood viscosity. Both will lead to increased peripheral vascular resistance and result in hypovolemic shock. Factors that increase the risk for death with burns include patients that are greater than 60 years old, burns that are greater than 40% of total body surface area, and we will discuss how to calculate that a little bit later in the presentation, and then also whether there's presentation of inhalation burns, because we know if we have inhalation burns then we're going to be at high risk for respiratory compromise, respiratory failure, and respiratory arrest. So how are the elderly affected by burns? We know that our elderly have skin that is much thinner than a younger person. They also have some sensory impairments, so they don't necessarily feel things and don't notice they're being burned at first, so their burns can be severe, and also decreased mobility. Another thing that elderly have are slower healing times, so a burn has an increased chance for becoming infected. Our patients, because of their cardiac issues, and we see shifts that can occur and decreased output and things that are going to affect your heart rate, we can have a problem with increased risk for those heart impairments. They also have a decreased inflammatory and an immune response, so those patients are much more susceptible to getting infected and having other problems associated with that. They have a decreased thoracic and pulmonary compliance, and so that also becomes an issue. And then lastly, they have many pre-existing conditions, or many elderly do have these pre-existing conditions, such as diabetes, kidney impairment, or pulmonary problems that can worsen the effects of those patients during a time of burns. And just a little snippet about how the very young are affected also. We know that their skin is much more sensitive. They are dependent on a caregiver, so the caregiver needs to make sure that they are protected from extreme heat, extreme temperatures, and or anything that can cause problems with burns. They have a lower immunity, so that they are much more higher risk for infection afterwards. And if you think about it, they have a total body surface area that is much smaller than the adults. So if they're exposed to something, they are much greater at chance for burning a larger area of their body. So those are the things that affect the very young. This slide just shows you a variety of different types of burns at different depths. You might also want to look in your book on page 490. There's a great picture of a inhalation burn, and just scattered throughout that chapter you're going to see all sorts of burns that require fasciotomies, that also may show tendons and ligaments showing, so just take a look through your book also at some different burns. Types or causes of burns include thermal, chemical, electrical, radiation, and inhalation, so you need to make sure that you know the difference between them. Thermal meaning heat, chemical meaning a type of chemical that has come in contact with the skin. Electrical would be like lightning or some kind of electrical equipment. Radiation would be sun or light or burns of that sort. And then inhalation would be from something that we have inhaled, whether it's smoke or whether we've inhaled some type of chemical compound. So our thermal burns occur when there's exposure to dry heat, such as flames, moist heat that can scald or from steam, and then also from contact with hot metals or other kind of liquids. And I just kind of put this picture on here because I remember once we had a family member that had a birthday, and they were getting up in age, and the birthday cake was filled with candles, and when they lit all of the candles, it looked like the cake was on fire. So again, we got to be real careful about blowing out those candles, not getting too close to that, and or making sure that it's not close to anything else to cause a problem. And our chemical burns occur when there's exposure to caustic agents, and the caustic agents could be any kind of house cleaning products, industrial products, gasoline. There's a lot of other things out there. Anything that has the poison sign on it or the chemical sign on it, we would need to be careful with that. But those things are easily absorbed through the skin, so they not only can affect the skin and burning the skin, but they can have a toxic effect on the liver and the kidneys as well. With electrical burns, that occurs when there's an electrical current that passes through the body. Again, I mentioned it could be just from electricity itself, it could be from lightning, but it can cause severe damage, can cause loss of organ function, tissue destruction with potential need for amputation of the limb, can cause cardiac arrest depending on where it goes through the body and how it affects the cardiovascular conduction system, and then also can cause respiratory arrest. What we need to know as nurses, though, if a patient comes in with an electrical burn in the hospital setting through the ER, we need to be aware of an entrance and exit site, because typically you will find two different sites that occur with electrical burns. Radiation burns are our most frequent type, so this would be things like our sunburns that we see occur especially during the summertime when people are outside way too long without protective sunscreen on. Also, it can cause from therapeutic treatment from cancer, so our patients that have been going to radiation for cancer treatment are at high risk for burns. And again, we talked about the overexposure to the ultraviolet lights already. And then our last type of burn is our inhalation burns, which we have mentioned previously. This does cause damage to the alveoli and can alter the gaseous exchange, so that's why we have a really high chance for problems with respiratory arrest. It can occur from inhalation, like we talked about, from chemicals or smoke, being exposed to the smoke. And so this picture that I put on here, that it says, what should we be concerned with? What I want you to see is this this patient's mouth is completely black, filled with soot. This is a patient that would be at very, very high risk for edema and loss of the airway. So we would definitely have to be proactive in this. This patient probably would be intubated immediately to maintain their airway. If you look at page 489 in your book, it does have a nice chart of emergency management of these particular burns, so you might take a look at those particular pages, or that particular page also. The severity of burns are based on the total body surface area, or known as TBSA, and also the degree of depth of the burn. And so when looking at the size of the injury, it's important to note, not only for diagnosis purposes and prognosis, but it is also important for calculating different drug doses, fluid replacement volumes that the patient might need, and then also caloric needs, because remember, our caloric needs are going to be increased during this time of injury to the body. Rule of nines: the total of the sum is equal to the total body surface area. So if you look at our diagram, we have a patient that has a front and a back side, and you'll notice that there are numbers written on the head, arms, chest, legs, and genitalia. So if we give you a test question and it says that your patient is burned on its face, abdomen, back, genitalia, you would add 4.5 plus 18 plus 1, and you would come up with your total body surface area of 23.5, if I added that correctly in my head. Now, if I said that the total circumference of an arm was burned, then you would take 4.5 for the front side and 4.5 for the back side, and that would equal 9%. So that's how we figure our total body surface area for burns. Depth or degree of burns are classified as minor, moderate, or major, and then they can even be classified down further as superficial thickness, partial thickness, which has some subcategories underneath it, such as superficial partial and deep partial, full thickness, and then deep full thickness burns. If you will look at page 483 in your book, there's a nice little table, 26.2, that breaks this down, and you're wondering probably why are some of them have moderate, minor, moderate, and major written on it, such as the partial thickness. It depends on how much total body surface area is included in that burn. So that will make it either minor, moderate, or major. So I'm not going to ask you specific total body surface area things, but I do want you to understand why they're classified in those specific categories and how they are categorized. And then you might also want to note what the comments are on that particular chart. Injury depth, again, it's going to depend on how much skin tissue has been burned, whether it's gone through the epidermis, the dermis, the appendages, and then the subcutaneous fat. Just also remember that it can go as deep as the muscle, the ligaments, the tendons, and even to the bone. So if the burn is severe enough, we'll see depth all the way down to the bone. So the one thing that I do want to point out here is, you know, if our appendages are altered, we know that sensation, contractility, lubrication, and heat loss will also be an issue for our patients. So the deeper the wound, that's why we have problems with feeling and contractility and skin lubrication. That's why it becomes dry and hard. And also we have trouble maintaining body heat. Okay, this slide just talks about the different layers of skin as they are burned. The first picture is superficial burns. They will heal within 3 to 6 days of injury. Superficial thickness burns or partial thickness burns, they will heal 10 to 21 days out. Deep partial thickness burns will heal 2 to 6 weeks out. And then full thickness burns going all the way through the subcutaneous tissue cannot heal on their own, so you need to be aware of that. Also look at the difference in the way the pictures look. The first one is just nice and red. The second one has redness with blisters. The third one is black and now has some indentations in the tissue itself. With burns at a glance here, just several different pictures of real burns. Superficial, just red skin. Partial, you have the blistering. Full thickness, you can see how some of the layers of the skin have been damaged, and now we have shininess and oozing and weeping of the skin. And then with our deep full thickness burns, you can see that there's some ligaments that are showing there, and also we have dry, non-moisturized skin. Again, our superficial burns are like our ultraviolet sunlight burns or our burns from treatment from radiation, but this is limited exposure to the epidermal tissue. Desquamation occurs. Healing is rapid without scars or complications. Typically we have minimal treatment needed, but we do have pain control that is needed for this particular type of burn. Real pictures of partial thickness burns, again, superficial and deep partial thickness burns. We have the entire epidermis and portions of the dermis that are affected with these burns. The one thing I want to point out on this picture is if we have a circumferential burn of like a hand extremity, then we have at risk for loss of that extremity because of the swelling that is occurring and the potential loss of blood flow to the appendages, so that becomes a complication. Some more real-time pictures. Here we have superficial partial thickness burns. This is the upper 1/3 of the dermis that has good blood supply that is remaining. Our wounds are going to look pink, moist. There will be some blister formation. They will be blanchable, and our patients will have some pain. We have uninjured appendages that are at risk still because of the swelling, and then we have healing that is usually no scarring and also minor pigment changes. So not necessarily a change in the texture of the skin, but a change in the color of the skin. Deep partial thickness burns. We have extended deeper into the dermis. These have fewer healthy cells that remain. So these wounds look red, dry. They do have some white patches on them. Blanches is slowly or absent, and we'll see some moderate edema. These are less painful, again, because of how the nerve endings and where the nerve endings sit on the layers of the skin. They heal with scar formation, so these are potential patients that would need skin grafting to either correct cosmetically or correct functionally for our patients. Full thickness burns are destruction of the entire epidermis and dermis. There is no cell for regrowth. There will be hard, dry, and leathery wounds. They will have a waxy, white, deep red, yellow, brown, or black appearance. They will be non-blanchable because of the damage to the circulation itself. Hair follicles will not be intact. You may see eschar in some parts, and that is just simply dead tissue that will eventually slough off, and there may be some healthy skin tissue underneath it. But what we need to be aware of is that edema is present under the eschar, and we can have problems with circumferential blood flow, and if we have chest movement problems, breathing may be reduced also. Deep, full thickness burns extend beyond the skin and damage muscle, bone, and tendons. They will be black and have a depressed appearance. They will feel hard and inelastic, and also no pain or sensation will be felt with this type of burn. Some of the diagnostics now that we might see ordered on our patients that have come in with burns: blood analysis will reflect fluid shifts and direct tissue damage, and so some of the things we'll be looking for will be chemistry panels, complete blood counts, electrolyte assays, and those will tell us if we have problems with syndrome of inappropriate diuretic hormone. So that might be something that they look at. Urine cultures, liver enzymes, and then clotting studies. And if you will look on page 493 of your IGGI book, you'll notice that there's a nice big chart that talks about the different labs, so you can see what you can expect, whether it's elevations or decreases from that. Also, X-ray imaging will only be present if they think that there might be an underlying trauma, such as a fracture or something like that. And then other specific diagnostic studies would be done if deep organ trauma is suspected, such as renal scans, CAT scans, ultrasounds, maybe bronchoscopies if it is an inhalation burn, MRIs, and then ophthalmic evaluations if the face has been burned. So make sure you take a look at the lab ranges. Again, you need to know your normals, but we're going to see elevations of hemoglobin, hematocrit, BUN, and glucose. We're going to see a decrease in sodium and an increase in potassium and chloride. We will see a decrease in PaO2, increase in PaCO2, and a decrease in pH. So again, we're going to be in an acidotic state. Depending on if they were in a smoke or carbon monoxide situation, we might see elevations in that. Also, you're going to see decreases in total protein and albumin. Again, make sure you look at the significance of these abnormal findings, not just that you know that they're elevated or not, but why are they elevated and why are they depressed. Every shift we should be doing a full head-to-toe assessment, and then throughout the shift doing our focus assessments. And I just want to reinforce things that are important for each of these systems. So in looking at skin, of course, that's the obvious with a burn. We need to describe the burn itself. Signs of infection should be assessed for. Also looking for pale appearance, boggy and spongy to palpation, dry, crusty exudate, granulation, swelling and edema surrounding the skin, and then of course vital sign changes, because with signs of infection we're going to be watching for elevated temperatures, and then we'll be watching for sepsis that can also occur. Looking at our respiratory section, of course, shortness of breath is something that we need to be monitoring for throughout the shift. Listening for adventitious lung sounds, especially wheezing and stridor, which shows that there could be some pulmonary edema going on. Cough, what does a cough sound like? Is it dry? Is it wet and moist? And if it is wet and moist and we can get a sputum specimen, we want to do that. Are we hearing any hoarseness in the voice, which again is going to show that there's damage to the vocal cords and the upper airway? Is our patient having any problems with dysphagia and swallowing? And then again, we talked about the oral membranes. That is important to look at. If we see the black soot on the mouth, tongue, lip area, then we have to suspect that our patient could definitely have issues with airway compromise. Cardiovascular, we're listening to our heart rate and rhythm. For dysrhythmias, we're going to be assessing. Of course, we've already talked about in previous slides how our fluid and electrolytes can be altered. So we know that if our potassium level goes up or down, then we can have problems with dysrhythmias. We're going to be watching for edema, also signs of shock. And again, reminding you those signs and symptoms would be low blood pressure, tachycardia, weak peripheral pulses, decreased capillary refill, diaphoresis, and of course, altered level of consciousness. Many of these patients will be on hemodynamic monitoring like we learned at the first of the semester with an arterial line that is going to accurately measure for changes to the right and left side of our heart. Our blood pressures and our pressures of our heart are going to be much more accurate utilizing the hemodynamic monitoring than they would with a blood pressure cuff, and sometimes you wouldn't even be able to put a manual blood pressure cuff on these patients. So the one thing I want you to do is just review your central venous pressure and your pulmonary pressures for this exam. The next topic here is fluid and electrolyte. Again, looking for edema. Weight gain is going to be one of our most important indicators of weight and fluid and electrolyte problems, or fluid problems, I should say. Monitor our intake and output, making sure that they stay equal and that we don't have a fluid volume deficit or a fluid volume excess. And then we want to monitor our electrolyte trending. So what's happening with our electrolytes and what are we doing about them, and are we seeing any improvement? Renal, main thing here is our probably with severe are going to have Foley catheters in so that we can monitor the intake and output well. We may see a decrease in urine output. The urine color may become dark, and if the patient starts spilling any kind of protein in the urine, then we know that the urine is going to also have some issues with changes in consistency. Thermoregulatory system. Our skin temperature, it's going to be much harder for our body to maintain skin temperature because our skin is something that helps us maintain that. And then we need to monitor temperature readings. So another thing that might be available for patients that are in critical care areas would be a thermometer that is on a Foley catheter so that we can read that on a regular basis and it'd be much more accurate. Gastrointestinal, again, we did talk about the bowel sounds. We need to monitor those for decreased in bowel sounds or absent bowel sounds because we can have hypomotility that will occur because everything slows down. Also, these patients are going to be at high risk for the Curling's ulcers that we talked about. Many of these patients may have a NG tube in, especially our patients that are going to be on a ventilator. This is going to help cut down on aspiration and also keep the stomach contents drained. And then last thing on here is immunological. We do need to monitor our temperature, of course, for elevations, and also we need to monitor our white blood cell counts and their trending. So we want to know if our levels are getting worse or better. So these are just some certain focused assessments that you can do on your patients as you continue to take care of patients with burns. The phases of treatment for burns include resuscitative, acute, and rehabilitative phase. The resuscitative phase is the first 24 to 48 hours after the burn occurs. In the acute phase, this begins when the fluid resuscitation is finished and ends when the wound is covered by tissue. And lastly, the rehabilitation phase begins when most of the burns are healed and ends when reconstructive and corrective procedures are complete, and this can last for many years. In the resuscitative phase, we have the main priority, and that is securing the patient's airway. Also, we want to support circulation and oxygen or organ perfusion with fluid volume replacement. We want to keep our patient comfortable. We want to prevent infection, maintain body temperature, and provide emotional support. And we can't forget about the history. So we need to know about the pre-burn weight and height. Health history, we need to address cardiac, kidney, chronic alcohol or substance abuse, diabetes, any allergies the patient may have, recurrent medications or home medications that they're on, and then immunizations, specifically to the tetanus. And if vaccinations are unknown, then the hypertet or the tetanus immunoglobulin will need to be given. So for burns, shock, and fluids, we have to look at the goal of fluid resuscitation, that is maintaining vital organ function by providing adequate intravenous volume or intravascular volumes. So we need a large bore IV. A lot of times they put in a central line for this. Utilizing lactated ringer is one of the main fluids that they use. Parkland formula for fluid resuscitation is the formula that is utilized to decide how much fluid this patient needs to be getting. And also they titrate the fluids according to the urine output. So typically an adult output would be 30 to 50 milliliters per hour, and for a child it would be 1 milliliter per kilogram per hour. So with the Parkland formula for fluid replacement, I do want you to know how to utilize this formula. 4 milliliters per kilogram per percent body surface area would equal the total 24-hour fluid needs. So in the first 8 hours, we would get half of the amount of fluid, and then in the next 16 hours, we would give the remaining fluids. Again, our fluid of choice is lactated ringer, and for pediatric patients, they will need additional maintenance fluids. Typically, they will use D5 1/2 normal saline due to the limited glycogen stores. So to use the Parkland formula, I'm just going to give you an example. Remember, our formula is 4 milliliters per kilogram per total body surface area for 24 hours of fluid needs. So if we have a 100 kilogram weight man with 20% of total body surface area burn, we're going to take our 100 kilograms times 4 milliliters times 20, which is the 20% body surface area, and that's going to come up to 8,000 milliliters of lactated ringer in the first 24 hours post-burn that we're going to give. Remember, the burn time starts at the beginning of the burn, or when the burn occurs, not when the patient comes to the hospital. So it's from the initial time of the burn. So with that said, if our patient then needs 8,000 milliliters of fluid, we're going to divide that by 2, and in the first 8 hours, we're going to give 4,000 milliliters. We'll have to divide the 4,000 by 8 hours, and we're going to come up with 500 milliliters per hour that we're going to be giving them in the first 8 hours. In the second 16 hours, we're going to be giving 4,000 milliliters of fluid, and we're going to divide 16 into 4,000, and that's going to come up with 250 milliliters per hour. Sometimes we do have to look at boluses and rate increases as needed. The one thing I want to remind you of, again, you can see that these fluid volumes that we're giving on an hourly basis are quite high. So any patient that has problems with their heart, lungs, kidneys, we can definitely get into a fluid volume overload. And even if they don't have problems, we need to be assessing those patients closely for that. In the acute phase, it's going to be important to assess all body systems, also management of wound care, pain control, infection prevention, and mobility. And one of the important things for nursing is assessment. So we are going to assess the systems, and we're also going to assess the burns. On our respiratory assessment, remember that prioritizing is going to be important. So continuous respiratory assessment is going to be our nursing priority. We're going to monitor for a hoarse voice, a brassy cough, drooling and dysphagia, and also for audible wheezing and crowing or stridor sound. Again, I think I mentioned earlier that if we have any burns on our lips, face, ears, eyes, eyelids, eyebrows, eyelashes, those are strong indicators that our patient has had inhalation burns. And just like we talked about the soot color in the mouth, that also is going to be important for us to look at. We want to assess any singed nasal hairs because those are indicators, and then black carbon particles on the nose, mouth, sputum, and then edema of the nasal passageways and a smoky smell to our breath are also concerns to us when we do our assessment. The other thing I want you to think about is patients with severe inhalation injuries have rapid obstruction within a short period of time. So when we hear the wheezing and then all of a sudden the wheezing disappears, then we have to definitely know that this is an indication that we have an impending airway obstruction and it does require immediate intubation. So the cardiovascular assessment, some of the things that we need to think about is hypovolemic shock, because that is a common cause of death in the resuscitative phase that we need to be aware of. We're going to monitor our patients for cardiac signs and symptoms of hypovolemia and also decreased cardiac output using the invasive hemodynamic monitoring. So we'll be watching for things like tachycardia, decreased blood pressure, decreased peripheral pulses, delayed or absent capillary refill. And then also peripheral edema and daily weight is going to be important for us to trend, and then watch for EKG changes and monitoring of those fluid and electrolyte balances. In our kidney and our urinary assessment, we'll see changes in kidney function with burn injuries that are related to decreased blood flow and also cellular debris. During the fluid shift, blood flows through the kidneys that may not be adequate for filtration. And also we'll see some destroyed red blood cells that are released, that release hemoglobin and potassium, and myoglobin is also released from the damaged muscles, and this will cause a sludge that forms. So then our kidneys become blocked and we don't have a good flow of blood to our kidneys or urine flow, and this can cause kidney failure. So for nursing, we want to make sure that we're monitoring our urine output. We're looking for decreased urinary output, compare it with IV fluid intake. Also looking at the specific gravity, making sure our patients stay well hydrated, and noting the color, odor, and presence of any particles or foam that may be present in the kidneys or in the urine that would address a kidney problem. Then the other thing we're going to do is trend our labs, looking at the BUN, creatinine, and then also our serum sodium levels. Continuing with kidney and urinary assessment, again, hourly output is going to be important for nursing to maintain good records, and we will look at the output and make sure that it is adequate. We're looking at utilizing Foley catheters because that is the most reliable way for us to monitor an output. And then we're looking at increase and decreasing in IV rate according to what the urinary output is. So in other words, we're titrating our IV fluids according to our output. And remember, the gold standard is 0.5 milliliters per kilogram for adult, or 0.5 milliliters per kilogram per hour for an adult, which roughly relates to about 30 to 50 milliliters per hour. Skin assessment that we're going to look at on our patient, utilizing the total body surface area with the rule of nines, and then also the signs and symptoms of infection. So those are going to be the main things that we're looking at with our skin. So look at that rule of nines that was mentioned previously in this PowerPoint and make sure you know how to calculate the total body surface area according to that. Gastrointestinal assessment. I want to remind you that there is a decreased blood flow and sympathetic stimulation that will reduce GI motility and promote development of paralytic ileus. So it's going to be very important for nursing to assess our GI status of our patients. We are monitoring for hypoactive or absent bowel sounds, looking for nausea, vomiting, and abdominal distension. If an NG tube is in place, we are going to be making sure it is patent and that the placement is correct. And then the other thing is we want to visibly look at the stools and emesis for blood, and also test them for occult blood as needed. Priority collaborative problems will include potential for decreased oxygenation, potential for shock, pain, both acute and chronic, and then potential for acute respiratory distress syndrome. In planning, we need to look at expected outcomes, and that would be support oxygenation, prevent hypovolemic shock and inadequate gas exchange, manage our pain and our alterations in comfort, and then preventing ARDS. And we've already identified this, but priority is monitoring our respiratory status. So we do want to support oxygenation by making sure that we do good respiratory assessments and monitor that status. So airway management is going to begin at the scene, may needing nasal or oral intubation if needed, suctioning PRN because sometimes they have problems with some thick secretions that develop. We want to promote ventilation, removing any tight clothing, and then we also have to watch for wounds or burns that become tight because we don't want to have like chest expansion be altered because of a tight skin on the chest. Also looking at monitoring gas exchange, so trending and monitoring our ABGs, carboxy, hemoglobin levels, chest x-ray, our pulmonary artery pressures, and our central venous pressures. Then also we're going to administer oxygen that is humidified, whether it is via nasal cannula or face mask, support intubation and ventilatory support. So we're going to monitor our arterial O2 levels, and we want to make sure that they stay greater than 60. If we have arterial levels that drop below 60, they are definitely in need of ventilatory support. We want to make sure we keep emergency airway equipment at the bedside, such as an ambu bag and other things. Then we want to position our patients and encourage deep breathing. So we can encourage them to take deep breathing, slow deep breaths, but we can also encourage them with the use of incentive spirometer hourly. We're going to monitor and care for tracheostomies and chest tubes if they're in place, and then we're going to administer medications as prescribed. So I'm thinking things like antibiotics. If our patients have pneumonia, we want to make sure that we're clearing that infection. Also giving beta blockers to these patients because that will improve the left ventricular function and then help prevent and treat pulmonary edema. We may need to give diuretics, but again, that's going to depend on whether or not our patient has the blood volume and they have adequate kidney function. And then paralytic drugs would just be used if we have a patient that is intubated and on mechanical ventilation. Along with that, we may have to give sedation, analgesias, and anti-anxiety medications unless they are contraindicated. Preventing hypovolemic shock and inadequate gas exchange. Nursing care would include monitoring vital signs, our blood pressure especially, and peripheral pulses. Also looking at our SpO2, PaO2, and PaCO2 levels. Rapid infusion of IV fluids, which is also known as fluid resuscitation. We will be administering IV fluids according to our Parkland formula. We need to monitor central venous pressure, pulmonary artery wedge pressure, and cardiac output hourly, monitoring our ECGs for dysrhythmias and possibly ST elevation changes if we might suspect that our patient could have cardiac issues or MI, and then also with escharotomy or fasciotomies that would be performed by the physicians, we would need to recognize if those procedures might need to be done and or help with those procedures, and then monitor and take care of our patients after them. We need to manage pain and alterations in comfort, so priority nursing actions would include continual assessment of pain using appropriate pain reducing strategies and also preventing complications from pain. We can expect pain to be alleviated or reduced with pain and comfort measures. So patients who are not relieved by pain reducing measures, we need to alert the provider for that. They may have excessive swelling that is causing them to have possibly a compartment type syndrome. We're going to monitor for complaints of pain. We'll be watching for moaning or crying, any facial grimaces, and even loss of appetite can be a sign that our patient is in pain. Administration of pain medication is going to be a big one. Utilizing opioids such as morphine, hydromorphone, and fentanyl. They may use PCA. IV route is always recommended. We don't want to give opioids IM or sub-Q due to rapid absorption when fluid shift is resolved. So that's something you need to be aware of. And then sometimes they give anesthetic agents also, like ketamine or nitrous oxide, to help with pain for our patients. Other things could be non-opioid analgesics, and then we can't forget that we need to utilize complementary therapy and also environmental changes. So things like imagery and distraction and providing a quiet, calm environment are going to be important for these patients to help control their pain. And lastly, we want to prevent ARDS. So interventions that focus on increasing lung compliance and improving PaO2 levels are going to be important. Priority nursing actions will be coordinating with respiratory therapy strategies and also monitoring the response to any interventions that are that occur or have been taken place. Utilizing pulmonary expiratory end pressure, intermittent mandatory volume to enhance effectiveness. And then we need to monitor our SaO2s and our ABG levels and make sure we are trending those, looking at the levels, how they're changing and what we're doing about them and if it's working. In the rehabilitative phase, psychosocial adjustment is an important thing that we need to be aware of. Prevention of scars and contractures, because as our wounds start to heal, we may see some thick scarring and also some contractures that can affect mobility and activities of daily living. So your book has and talks about some things like therapeutic devices, which are compression garments, and those are applied after the grafts are healed. They help prevent contractures and tight hypertrophic scars, which can inhibit mobility. They also inhibit venous stasis and edema in areas with decreased lymph flow. So they must be worn at least 23 hours a day, every day, until the scar tissue is matured. And we need to remind patients that they may have problems with some itchiness during warm weather, but it's important for them to wear them to help prevent these problems. So that's going to be a huge issue. So resuming pre-burn activities is definitely going to be our goal in our rehabilitative phase, and that's where we're going to try to work to get our patient. Some of the pharmacology that we may use throughout treatments of burns might be sulfonamides, and the reason I picked some of these is because of some of the nursing implications that we need to be aware of. So sulfonamides are antibiotics. They are contraindicated with hepatic and renal impairment. Some of the side effects can be rash and nausea, and on the nursing implications, we need to instruct our patients to wear sunscreen for this particular medication. The other one is nitrofurazone, which is a topical antibiotic that is contraindicated if our patient has renal impairment. Side effects of this one can be itching, rash, and swelling, And then nursing implications would be monitor for worsening of the wounds. So again, a lot of these medications, we need to make sure that our kidney function is well before we give them. And we can't forget about our nutritional needs on our patients. High calorie, high protein diets, offering nutritional supplements, asking yourself why. Again, when we talked about burns at the very beginning, when we have large surface of burn areas, our patient is put under a hypermetabolic state, so we're burning calories at a fast rate. So we want to make sure that we are replenishing them so that we can have good wound healing. The nurse plays such an important role in our patients with burns, and so things that are very important is that we are a good caregiver, that we provide optimal care to our patient in a safe manner, that we are good patient advocates, and that when we see problems arise, that we are visiting with the primary care provider, the therapists that are involved, and also we want to be a collaborator. If we don't share things with the other therapies, our patients are going to have problems with potentially activities of daily living, getting back their strength, and so forth. And then education is very, very important. So we're educating not only our patients, but we need to educate the families so when the patients go home, they can be taken care of properly and help prevent any complications. And I always ask you to put on your thinking caps. So we want to prioritize our nursing actions, and we have to think about what we will be taking care of, what will we treat. So if I have to ask you the 5 main things on patients with burns, I want you to be thinking of maintaining airway. Our patients may need to be intubated and administer humidified oxygen. I want you to think about treatment of burn shock. So fluid administration utilizing the Parkland formula is going to be really important, and monitoring problems for that. Number 3 is going to prevent infection. So we may need to make sure that our patients get baths and showers, that we're applying our sulfa and our antibiotic topically, and covering our wounds utilizing sterile technique, and then watching for signs of infection. The 4th thing, we want to treat ongoing pain with morphine and or what other medication has been ordered. And it's always a good idea to do that prior to doing dressing changes, because these dressing changes may be very uncomfortable for the patient. And number 5, providing nutrition. Not only oral nutrition, but some of these patients may need special IV fluids. They may need TPN fluids, and some of our patients may even have tube feedings. So I want you to be thinking about how you would care for the patient and these particular things to provide excellent nursing care. And lastly, let's just talk a little bit about health promotion and maintenance for prevention of burns. So first off, we want to make sure that we are planning and provide awareness for our patients and their families to help prevent burns. So we want to have our patients assess the water temperatures, making sure that the temperatures in their house are not higher than 140 degrees Fahrenheit or 60 degrees Celsius. Make sure that there are not any cooking issues, avoiding adding flammable substances or open flames. Make sure we use sunscreen and encourage them to use sunscreen and protective clothing when they're outside. Discourage from smoking in bed or drinking alcohol or with drinking alcohol and drugs. Keep matches and lighters out of reach of children and those people that are cognitively impaired. Making sure that space heaters are used wisely, fireplaces are used safely, and if home oxygen is used, that we have oxygen safety signs and that there is no smoking around oxygen. Adequate work and smoking, adequate smoke and carbon monoxide detectors are important to prevent severe inhalation or severe burns, so that we're alerted when there is a problem. Making sure that families have a fire plan and escape route alternative, and also stressing that we never enter a burning building for anything. So those are just some health promotion and maintenance for the prevention of burns. A few cultural, ethical, and legal issues to consider. African Americans are at high risk for sickle cell crisis with known disease and traits, and with burns we can have even worsening episodes that can occur. So testing if unknown is going to be important. Also thinking about the elderly and the young, we want to make sure that we never leave them unattended, that we never leave them home alone, and that they're always protected. Just want to wish you all a good day. We just made it through theory number 9. We do have a skills lab that is coming up, so make sure that you are ready for that one also. I hope everybody has listened to this PowerPoint and has taken some notes on some of the things that I've shared. Make sure that you view over this PowerPoint prior to your test number 4, and make sure you utilize your homework and your readings as far as layered learning. So have a wonderful day.